So, Sachin sir, we are live.
Yeah, okay. So, hello friends. This is the third case discussion in the Project Pelvis case discussion series. And our previous two case discussions have had fantastic responses of almost 1500 to 2000 views on YouTube after being conducted live. So carrying forward, this is a case which can come across not to all gynecologists, but in case it comes to your OPD, then how you would want to manage this case, it's a ideal case in that. So Jay, uh, recently a 33-year-old girl was referred by an oncosurgeon who wanted to start chemotherapy as soon as possible for a locally advanced lesion of CA breast.
Okay.
Okay. Her ER, both are positive and Ki67 is also positive.
Okay.
All right. So now she basically came for oocyte freezing or embryo freezing.
Right.
Okay. So she
Uh,
wanted options whether she should freeze oocytes or whether she should freeze embryos, and she's a married woman.
oh, okay. So, two, three things. I mean, just from this first few lines, she is 33-year-old diagnosed with CA breast. A young lady who is typically diagnosed with CA breast may have a slightly aggressive disease and may have a slightly poorer prognosis. That is just one thing which we must remember from gynecological perspective. Second, you mentioned it is a locally advanced disease. So
Mhm.
in locally advanced diseases, post-surgery, chemo plus radiation, local field radiation, or pre-surgery chemo, and then surgery to reduce the size of the mass if in case she wants to opt for breast conservative surgery. Okay. And then another 4 to 6 cycles of chemo followed by local field radiation. Okay. Something like this is typically attempted. And that is going to completely knock out her ovarian reserve. Absolutely completely. So, in this situation, and since you said she is married, see, one thing we must remember for a married lady, unless she is planning to get divorced, okay, embryo freezing is the treatment of choice because the overall retrieval of an embryo post thawing is close to 95 to 98%, day 5 blastocyst embryos. And a good embryo is otherwise going to give this lady a success rate of close to 40-45%. So that is something which we must keep in mind as compared to oocyte freezing, where even in the best of the hands, there is going to be approximately 5 to 10% degeneration of the oocytes, depending on the freezing technique. And post ICSI in frozen oocytes, the live birth rates are going to be approximately 20-25%. So you are reducing the success rates by half by
Half.
doing egg freezing. So embryo freezing technically is the treatment of choice.
Yeah, so we counseled her that exact thing that instead of freezing oocytes, you should go for embryo freezing since you're already married. And there's a very
Correct.
funny thing. One woman once came, she was married, but she came alone and she asked about oocyte freezing. So I
Yeah.
told her, Madam, you're married. Why do you not want to freeze your embryos?
Mm,
And this girl was married since 5 years.
mm,
So she was like, yes, I am married to this guy, but I'm not sure whether I want to have embryos with him.
yeah.
So, sometimes we might also get such patients
Yeah.
where,
Common.
yeah, where we have to explain them oocytes and embryos because it is a very mixed concept that they have. So, fantastic
Yeah.
point that you said. So, when we scanned her, Jay, she is on day 9 of the cycle, and there was
Mm,
a dominant follicle of 13 mm.
yeah.
So should I give her a course of oral contraceptive pills to downregulate her and then do a cycle next month? Her AMH is 1.7.
Yeah. See, basically, in any form of malignancy, if you are mentioning the word locally advanced disease, no, so that means the onco team will want to do some therapy on an immediate basis. It can be
Yeah.
either radiation or chemo. One of the two they will want to do on an immediate basis. And typically, as far as breast is concerned, cyclophosphamide is one of the chemotherapeutic agents of choice,
Yeah.
along with fluorouracil. So normally what happens is when you use these two agents as treatments for chemo, they are absolutely destructive to the ovaries. Okay. And our onco team will, desperately wanting us to send her back to them in 9 days, 10 days, 12 days, whatever. So if in case you are to skip this cycle, I don't think it is a good option, sir. I think the treatment of choice here will be to counsel her. And, in oncofertility, it's simple. You should start stimulation before the patient comes to your OPD. Okay, that is the joke. Where I was recently addressing somebody in the Apollo Fertility and Cancer Conclave. That is what we started off with, that patient should start stimulation the minute they leave the onco's cabin and they before they come in the fertility cabin. So it has to be that fast. So in this situation, you mentioned 13 mm, 14 mm dominant follicle, day 7, day 8, I think day 9 you mentioned
Day nine,
of the
day nine.
cycle, day 9 of the cycle. We will simply attempt random start stimulation. Random start stimulation also we will cut it down. So we will give her antagonist, two shots of antagonist today, basically, and we will start her off on stimulation from tomorrow. 9 days of stimulation. Do the egg pickup on the 11th day. On the 13th day, she is back to the onco to start chemotherapy.
So before starting stimulation, should we be aspirating this 13 follicle so that all the follicles are of the same cohort size?
Sir, this antagonist, two shots, zero 0.5 antagonist is basically destructive. So it is going to stay in the body for approximately 24 to 28 hours, and it is going to virtually cause apoptosis of this oocyte if there is an oocyte inside this follicle.
So the two doses of antagonist means cetrorelix. Would you want to
Yeah,
give both
Ganorelix or
together?
Cetrorelix.
Would you want to
You
give
can
both
give
them
both
together
together or you
or
can
one in
give
the
them 12 hours
morning?
apart. That's both are equally fine. Both are equally fine. Doesn't matter.
Oh, okay, okay, all right. And do we need to give her letrozole?
100%. In any malignancy, even if it is breast, no breast, let's say it is a hematological malignancy also, addition of letrozole is absolutely important. All protocols are with letrozole. Letrozole has to be continued even after trigger is given. Letrozole is to be continued on the day of pickup. Letrozole is to be continued till she reaches the oncosurgeon's or oncologist's office. Okay. Basically, letrozole should not stop because letrozole will do two things. One, it will keep estradiol under check. Second, it will make sure that even after your aspiration is done, it has some effect of luteolysis over these follicles. It will reduce the OHSS. Very little chances of getting abdominal pain. Does not interfere with the maturation of the oocytes at all after giving trigger because mechanism of action of letrozole is completely different. It is not receptor based. It is enzyme based, right? So the mechanism of action is completely different and it really helps these patients.
What dose of letrozole? 2.55,
2.5.
2.51 daily.
Yeah.
So that starts along with the cetrorelix.
Yeah. Cetrorelix plus letrozole. Next day, cetrorelix stops. It is letrozole plus HPHMG, whichever dose you want to give. See, we normally give 375 to oncofertility patients because we want that higher dose because we want a little faster stimulation. Otherwise, if in case and any which ways, this patient has AMH of 1.7 as you mentioned. So at 1.7, this is the perfect dose, 375. But if you want and if you want to be more vigilant, then even 300 is okay. It will just probably enhance the stimulation by 1 day or so.
Okay. And how about doing the PPOS protocol, the progesterone primed ovarian stimulation, or would you be doing the short antagonist protocol?
I will, sir, PR receptor is positive, no? So I don't want anything to be progesterone primed to be administered to oncofertility patients. In fact, it has to be anti-progesterone and anti-estrogen as an adjunct to our stimulation. So that's why letrozole with antagonist protocol with HPHMG work the best. PPOS protocol probably not required.
No, no, we were just thinking, because if we can add progesterone, we can save some money with the cetrorelix.
Yeah,
That's the reason. But
yeah,
yeah,
yeah.
she is PR positive, then why unnecessary to do
Sir,
that?
actually remember one thing. Oncofertility, this has been our experience. So on an average, considering all protocols, we will be doing close to let's say 15 to 20 oncofertility patients every month from our state. So what will happen is these people are not going to have that much money to do your IVF cycle, sir. Because see, even if you are looking at our broad-based scenario, the budget for getting CA breast basically operated in a good hospital or a decent hospital in twin sharing room is going to be around 2.5 lakh rupees in cashless. Okay, so that really saps out a lot of money from their financial aspect. Simultaneously, chemo and local radiation is another 2.5 lakhs. So it
Hmm.
really takes away a lot of money. So what we do is we do all these oncofertility protocols for patient at 1 lakh rupees. That's it. No matter what the condition is, we will do random start protocol for them at 1 lakh rupees. Okay, and it saves cost. They really don't have to run around to arrange for money because that is a big problem otherwise. And 1 lakh rupees is something which can be arranged immediately and started off. And even in that, using antagonist is equally cost effective. No problem.
Okay. Well, so you said that stimulation will go on for 9 to 10 days, right? And if we give
Yeah,
dose
yeah.
of 300, maybe a day more.
Maybe one day more.
So if we give dose of 450, will it be a shorter stimulation?
No, sir. Actually, shorter stimulation than 7 days will give rise to a lot of immature oocytes, even in random start protocol. Because random cohort is there, no? So here you will not have the same follicular cohort. You will have one follicle at 19, one at 16, one at 14. So basically, you want the lead follicle to be 23 in random start protocol, so that your other follicles are between 17 and 18 and 19. And then you need to ideally give a double trigger to all these patients. Because when you are giving a double trigger, even those smaller ones, 15, 14, you may get an M2. And if you get metaphase 2 sites in that, you are going to be like super happy.
Mm-hmm. Okay. What I've recently started doing, just we had a pickup today.
Yeah.
We are suspecting OHSS. So instead of doing a dual trigger, we've started doing something new for
Yeah, I know, I
hyperresponders,
know.
what is called as a
I know, I've
double
heard of this.
double
Double
agonist
loop
trigger.
ride. Yeah,
No, no,
double
no.
agonist trigger.
Yeah, so two lupride and decapeptyl. So that gives fantastic conversion, and
Yeah.
OHSS completely goes off. So
Entire
looking,
colony will have luteonisis at such a dose
yeah,
of
yeah.
agonist.
So tell me, Jay,
Yeah.
if we are giving her HCG trigger, won't there
Yeah.
be a chance of OHSS happening?
No, no, we are giving letrozole continuous, no, sir. So
Acha,
letrozole is given continuous. Does not happen, sir.
okay. And how many days after the pickup she can start the chemo?
2 days, 48 hours.
That's it.
That's it, sir.
We need
In
not.
fact, amazing thing happens. I don't know if you've got a chance to study it. Usually second, third day, the ovary is very edematous,
Hmm.
right? And when they give the first dose of chemo, no, sir, they usually call the patient they at least have a call after 2, 3 days because the primary reactions post chemotherapy will happen in the first 48 hours, acute acute leukopenia and all these types of things,
Yeah.
fever and all these types of things. So sometimes you will be surprised the ovary uh, will suddenly have so much luteolysis because of chemotherapy that ovary will be completely shriveled and
Oh,
devoid of vascularity,
okay.
so can be started in 48 hours, sir. No problem.
Now, if you're delaying chemo by these 9 to 10 days, are we risking her life?
No, sir. We are delaying chemo 9 to 10 days even after suspecting malignancy and waiting for biopsy report, no? And sometimes after the biopsy report comes, we are even waiting for IHC. Now, see, fortunately, in this girl, IHC is done. AI67, HER2 new, and all these things which you mentioned are positive. But if somebody wants to have a more detailed IHC, it will take another 10 days, no? So I
Hmm.
think it's okay.
And what do you think? Should we be giving her a GnRH agonist depot to preserve her fertility? And if yes, why? If not, why?
See, a lot of people will give GnRH agonist depot. There is no question in that,
Hmm.
with
Hmm.
what thinking कि अरे यार जो help करेगा वो करेगा types.
Hmm.
But
Hmm.
you should remember that even after giving GnRH agonist, 90% of the ovarian reserve is going to get destroyed after the first cycle of chemotherapy.
Hmm.
Okay. So when you have such a low AMH, I mean 1.5, 1.7 of the patient, very marginal role of any benefit of giving a depot. Better is you preserve the embryos, no? Once the embryos are preserved, then you go ahead. Now, one question people will ask here, it's a tricky question, that you are saying you start chemotherapy on day 2. What if the patient does not form embryos? What if
Hmm.
there is no day 5 embryos which are formed in this patient? So that has happened to us 2, 3 times where patient has not formed embryos only. Okay. Honestly, nothing much can be done about that. Really. Okay, because after that chemo is taken inside, you can't even do egg pickup. Nothing will
Hmm.
come out of those ovaries. So that is a tricky situation. there will be an opinion where people will say, no, you just wait till blastocyst embryo is formed, and only then you allow the chemotherapy to start. But I think for practical purpose situations, we allow people to start in 48 hours, provided the patient has given 7 metaphase 2 sites.
Hmm. Okay. And any role of ovarian cortex preservation, cryopreservation?
You tried it, sir, in 10, 11 patients, but it's first of all, the kit is very expensive. Okay, the cost of the kit is 1,90,000,
Oh.
and it is not available in India. So you have to import the kit. So
Hmm.
basically, now we are the importers of this kit in India. But what typically happens is, see, in order to do that, you have to do a laparoscopy. So it is an invasive procedure. Then you have to have the entire setup. You have to have everything right from cryotome to cryoprotectants to preserve everything very fast, and you need frozen section. So I think for a practical purpose scenario, see, our hospital is doing everything. So we have all these facilities in house. But for other IVF clinics who are hardly seeing onco patients, it is going to be a very tough bet, you know. And if it is a
Hmm.
tough bet, I don't think it is a viable option in Indian scenario.
Right, right, right. No, no, I think that was great. So all the queries are resolved, and we'll counsel her further. Any queries in the audience? Anybody's got some
Yeah,
queries they
I
can.
think we spoke about this random start protocol in our classes also. And what has been your experience? Because many a times the patients will say that they went to another consultant and they said wait for your periods on second day and all that. So
Very
do you
common,
think
madam.
that
Yeah.
yeah? So do you think that in random start protocol you get a same almost similar kind of the numbers in the oocyte like M2 oocytes or
One,
have you?
you require 1 day more of stimulation, and you can expect one oocyte less.
Yeah, yeah. Okay. And
So
hmm,
that is the standard, to be honest.
okay. So the other thing
But
that
remember, sorry, I wanted to add this point. Uh, in random start stimulation, there is only one problem. You can't do embryo transfer in that cycle because it is
yeah,
completely random. So you have to do FET only, right? So if you are planning for a fresh cycle, then random stimulation is simply not possible. Not
yeah,
possible to do.
yeah. So see the same situation. She's on day 9 and the follicle is 13 millimeter. You see that there is a beautiful follicle 80 millimeter and you see good vascularity on day 11 probably. So you would aspirate
Yeah,
that? I mean, you would trigger aspirate and then start the stimulation or you would just
madam, that antagonist is a killer. I'm telling
yeah,
you. So if in case, I mean, see, if you want to be super sure mentally, you can aspirate it and go ahead. But since you have given antagonist, I'm telling you, we don't even give 2 days of antagonist. We give single antagonist, single shot, 1 day, 2 shots in the hospital. Okay, that luteolysis for 24 to 28 hours is so profound. Okay, that it will cause apoptosis, madam, of that
hmm,
oocyte because there is no FSH. See, it goes and blocks the GnRH receptor, no? So there is no, apart from basal FSH, there is no FSH. And
yeah,
basically, you require that certain threshold of FSH to sustain the estradiol. If
hmm,
that doesn't happen, the oocyte undergoes apoptosis.
yeah.
So
I know that you spoke about all these OncoFertility principles in the recent talk in that Apollo Fertility, what you were saying. So, what do you think are like, the most important principles, especially when you're dealing with these, the stimulation protocols for OncoFertility patients, especially in your experience?
keep the estradiol to a bare minimum, even in
Okay.
ER negative cancers, even in ER negative cancers. Okay, because remember one thing, your high estrogen is then going to be a risk for thromboembolism, and our onco friends don't like thromboembolism at all. They like everything else, but they don't like thromboembolic episodes on chemo, in surgery, whatever it is, right? Because their surgeries are prone to embolism. That's
Yeah.
one of the reasons why they are so cautious about all these things, right? Second is the time. Very important. You can't waste time investigating and all these types of things. Okay. In fact, I'm very lucky to have some fantastic onco friends. Okay. So what they do is they even send the patient till the time they are awaiting biopsy reports.
Yeah.
Okay. So that they don't even want to waste that time. Like that is exactly what has happened in today's case. So there is a endocrine oncosurgeon by the name Dr. Agarwal, Ritesh Agarwal. He's very well known here in the city of Bombay, and he diagnosed somebody with CA breast. He's like, I'm taking a biopsy. All reports are CA breast. Till the biopsy report comes, please go to Jay. And we want a confirmation from one more histopathologist. So he's like, one report we've got. till the time slide and block is getting reviewed, just start your protocol, because by the time slide and block review comes inside, okay, in that situation, he wanted to start the patient on treatment.
So among 10 patients, how many of them would convert into actual, like, starting the stimulation? Because it also depends on the counseling done by the onco surgeon or the medical oncologist, and the urgency in which they tell that their treatment is important. Because, like, whoever comes to me, I mean, at least they have not started stimulation 10 on 10. At least, like, only two will come up, and then the others will be like, no, it's okay. We just want to go ahead with the onco treatment. We don't want to do this at this time and lose out on those 10-12 days. So what do you think is the most important thing when you actually try and tell them that, yes, this is important?
It's always our onco friends only, madam. See, it depends on how good their counseling is and how,
Yeah,
you know, how
desperate.
strong or convincing they are. See,
Okay.
they are very meticulous about their histories, no? So if in case they think that the patient has completed childbearing, they will not offer all these things because they know the cost of all these things. It's additional 1 lakh rupees, right? So they know the cost involved in all these types of things. But for people who are young and all, we have never had a problem, madam.
Hmm. Hmm. Okay.
Or
So
maybe I'm too charming, so they just look at me and they start.
it's okay. We'll
No,
pass
so
that.
once
So,
once we had a patient, her AMH was 1.2, 1.3. We did the random start protocol for her. And after giving a dose of 450, we gave her antagonist for 3 days and started with HMG 450, gave for 5-6 days, and there were only 2 follicles which are recruited. So then we took a call that, it does not make sense to go ahead because her response was not that great, and we canceled the cycle and told her to finish off your chemotherapy and all that because it was a very aggressive tumor. So have you come across situations like that, Jay?
Absolutely, sir. It's bound to happen when you do random start protocol. Because how many follicles are there in the cohort at that day is an answer which nobody knows, sir. Correct? Because they are very small follicles. Correct?
Yeah.
So it is an answer which absolutely nobody knows. And it is bound to happen like this. Some patients you will have 10 follicles, maybe some patients you will have 6 only, despite having an AMH of 5.
Yeah.
yeah.
Something like that. It's bound to happen in random start protocols.
Hmm.
Correct, correct.
Yeah, I
Super.
think we have covered. So which are the common cancers that you have come across where you do this, the stimulation protocols?
Hematology and breast. Hematology, breast and colon. 3.
Hold on. Hmm. Okay.
Done. Super. I think that was
Okay.
a great session. Thank you so much, Shilpa
Okay, sir.
madam, for your inputs. And you can go back to your factory.
No, sir.